Let's dive straight into high-yield Step 2 CK neurology decision logic for CNS tumors and neurocutaneous disorders, zeroing in on exactly what you need for the exam. We're starting right off with brain mass presentations.
First up, identifying the specific symptoms of a new brain mass.
When you're dealing with a new brain mass, the key is separating a standard headache from signs of raised intracranial pressure. Things like vomiting, papilledema, or hydrocephalus. Keep a close eye out for new onset seizures, specific focal deficits, distinct personality changes, or shifts in visual fields and hearing. You also want to look for crucial history clues, like if the patient is immunosuppressed or has a known cancer history. And always anchor your differential on whether you're looking at a child or an adult.
Moving on to adult CNS tumors.
Metastatic lesions are incredibly common in adults. They classically show up as well-circumscribed lesions with vasogenic edema right at the gray-white junction. Now, if an MRI with contrast shows multiple brain metastases, you're going to prioritize lung cancer or malignant melanoma. But if you're looking at a primarily solitary metastases, that points more toward breast, colon, or renal cell carcinoma.
So how do we manage this? If you have a patient with good performance status and a single surgically accessible brain metastases, they should undergo surgical resection. After that resection, the next step is stereotactic radiosurgery or whole brain radiation, which really depends on the exact clinical context and the specific tumor type. Take a look at a parafalcine meningioma. On an MRI, it presents as an extraaxial, homogeneously contrast-enhancing mass, and you'll often spot that classic dural tail. Keep in mind the risk factors here: older age, female sex, previous radiation exposure, and neurofibromatosis type 2. These tumors can range from completely asymptomatic incidental findings to causing headaches, seizures, focal weakness, visual changes, anosmia, hearing symptoms, or even obstructive hydrocephalus. Your decision logic here is straightforward. Observe small, asymptomatic tumors with serial imaging, but if the tumor is large, symptomatic, or causing edema, you're pursuing surgery. Radiation is reserved for non-resectable tumors or patients who are poor surgical candidates.
Next is vestibular schwannoma, a Schwann cell tumor of cranial nerve 8. In adults, these are typically unilateral, unless they're associated with NF2. The classic presentation is progressive unilateral sensory neurohearing loss, tinnitus, and imbalance. You might also see facial numbness or paralysis if cranial nerves 5 and 7 get compressed. For the workup, you need an audiogram and a contrast MRI of the internal auditory canal. Management spans observation, surgery, or radiation, all depending on tumor size, the symptoms, and the patient's age.
Let's shift gears to pediatric and spinal tumors.
Choroid plexus papilloma is a rare, slow-growing, benign tumor found in infants. What's unique here is that it actively increases cerebrospinal fluid production. That leads directly to enlarged ventricles and hydrocephalus. Once you diagnose it with an MRI, surgical resection is your primary treatment.
Now, suspected epidural spinal cord compression requires rapid recognition. It's a true emergency. If a patient comes in with severe back or radicular pain, weakness, a clear sensory level, or bowel and bladder dysfunction, especially if they have a history of cancer, you need to act fast. Step 1 is administering empiric high-dose glucocorticoids immediately. Then get an urgent MRI, followed by rapid evaluation for radiation or surgery.
Moving into the neurocutaneous disorders, starting with neurofibromatosis types 1 and 2.
For NF1, the classic cutaneous findings include café au lait macules, axillary and inguinal freckling, and multiple cutaneous neurofibromas. Systemically, it's associated with learning disabilities, scoliosis, and a definitely increased risk for developing a pheochromocytoma.
You also want to look for Lisch nodules, which are iris hamartomas that essentially confirm the NF1 diagnosis. Because there is a serious risk of optic pathway gliomas, yearly ophthalmologic screening is critical. Any new vision changes mean you need an immediate MRI of the brain and orbits.
When you contrast NF1 with NF2, the differences are stark. NF2 is defined by bilateral vestibular schwannomas, intracranial meningiomas, spinal tumors, cataracts, and skin plaques. Because of this, NF2 surveillance relies heavily on routine audiograms, thorough ophthalmologic evaluations, and serial MRIs of both the brain and spine.
Next, tuberous sclerosis complex. Tuberous sclerosis is caused by TSC1 and TSC2 mutations and presents across multiple organs. Cutaneous signs are highly distinct. Look for hypopigmented ash leaf spots, facial angiofibromas,
thickened shagreen patches, and ungual fibromas around the fingernails or toenails. Neurologically, there's a critical link to severe seizures, most notably infantile spasms, as well as intellectual disability and autism. Systemically, you have to screen for specific tumors, primarily cardiac rhabdomyomas and renal angiomyolipomas.
On an MRI for tuberous sclerosis, you'll see the classic subependymal nodules and lesions. Neurologic impairment often includes severe seizures and obstructive hydrocephalus. Comprehensive surveillance is intensive here and requires regular skin and eye exams, serial MRIs of the brain and kidneys, baseline echocardiograms, ECGs, EEGs, and routine neuropsychiatric screening.
Finally, let's cover von Hippel-Lindau and Sturge-Weber syndromes.
For von Hippel-Lindau disease, memorize the core diagnostic triad: cerebellar and retinal hemangioblastomas, clear cell renal cell carcinoma, and pheochromocytoma. Surveillance is heavily focused on regular retinal exams, checking plasma or urine metanephrines, and serial MRIs of the brain, spine, and abdomen.
We'll wrap up with Sturge-Weber syndrome. This is identified by congenital facial port wine stain in the trigeminal nerve distribution paired with ipsilateral leptomeningeal angiomas. Clinically, this leads to seizures and early-onset glaucoma, and on imaging, the hallmark finding you need to know is tram track calcifications in the cerebral cortex.